Greetings from a rainy Nantucket. Usually it's sunny and it's been sunny all week, but for today we brought out the special weather. We were just trying to compete with North Dakota back in May with all the snow that you had. You were making the news around the country. So let me say a little bit about myself. I was at Johns Hopkins for 25 years in the Alzheimer's Disease Research Center and in the departments of neurology and psychiatry as well. I was the education specialist there. So my job was to educate other medical individuals doing continuing medical education and also lay education. And I taught at the university a bit. My area of expertise is families and behavioral management, which is how I got to this space today to present this lecture to you. So we're going to be talking about non-pharmacological management of behavioral issues or challenges. And one thing I will say is I work very closely with Dr. Chris Moreno, and he will be speaking this afternoon. And we both like to stress that non-pharm is used first. And even when you have to layer pharmacological interventions on top, the non-pharm does not stop. Sometimes families will want to just give a pill and skip the non-pharm interventions, but we convince them that the pharmacy will work better if they manage to continue along with the non-pharmacological approaches. So behavioral issues are really one of the most difficult parts for a family who has a member diagnosed with a dementing illness. The memory issues alone really are not what brings people to their knees, but the behavioral issues can, because they can be shocking, they can be embarrassing, and sometimes there's flat out safety issues associated with them. So they aren't to be ignored because they can grow. For people who don't address behavioral challenges, you have an increased risk of placement into a facility where maybe they really could be managed at home. Very big risk of a decrease or a transfer out of a facility, and that really traumatizes the family. Overall increased cost of care for individuals, resulting in higher use of consultants, emergency rooms, so on and so forth. And most importantly for the caregiver, for a depressed, stressed caregiver, mortality and morbidity can be higher than that for their care recipient. So it's a pretty significant issue. I'm going to lobby today to have individuals learn to approach behavioral problems with a systematic approach, being consistent and comprehensive matters. And I hope by the end of this lecture, you'll see why I say that. When you systematically approach a behavioral problems, you generate greater number of solutions for the challenge. You increase the likelihood that you're probably going to be able to solve this. You can also teach your staff and your families to do this for themselves across time, which puts you as a professional in a much better situation. Finally, and the most important thing I want to say about this slide is it increases the tolerance and understanding of behaviors. One study that we did at Hopkins looked at dementia-specific facilities and non-dementia specific facilities. So obviously the dementia-specific had a lot of staff training. The non-dementia specific facilities had quite a bit less. And what we found in that research study is that pound for pound, the same patient with the same degree of behavioral issues created a lot less stress for the staff that had the training and understood what they were looking at. And it generated quite a bit more stress for a staff that did not understand what they were seeing and also didn't feel like they had the resources within themselves to manage things. So understanding behavioral problems and approaching them in a systematic way has a lot of benefits. As I mentioned already, good management of these issues creates less need to transfer to higher care units, less transfers out of places, but it also generates overall less behavioral problems across the board. Because sometimes you can start with one behavioral problem and it will morph into 2 or 3 others. So if that initial problem is managed in a little better way, you have less trouble down the line with other problems. And certainly for this population, your healthcare providers, it's less emergency and non-emergency calls to you, to your staff, to your office, and certainly limits the number of off-hour calls you get from families if things are managed reasonably. So how do we do that? I'm presenting today one of the problem-solving systems that we've been using at Hopkins forever and ever, and you can see by the year that this was published, 1996. It's an oldie but a goodie. What I'm going to be presenting to you is part this model and probably about 40% of it my own personal experience and personal tips on how to identify and manage behavioral challenges. So this is just a 5-step model, nothing too special about it. I think we've all looked at different behavioral models that do the same thing where you're describing, decoding, and figuring out a plan. But what I'm going to present to you today is a lot more detailed than what you will see in almost any book. So let's start out with step 1, describing the problem. This is a very big deal. If we don't know what we're dealing with, we don't ask enough questions, you'll get off to a wrong foot. So I ask people to describe the problem, and often from families, you will get sometimes a subjective response. Well, what happened? Oh, we really went off yesterday. Well, you know, that's not quite specific enough, so you can kind of encourage your families to use more objective terms so that you understand exactly what it is. There is a big difference between problems that start abruptly over the last week, week and a half, versus problems that have kind of reared their heads over weeks. And this is the first split here in your assessment that's going to put your behavioral problems into different baskets so that you can solve the problems. And I will say things that happen acutely tend to be medical issues. Things that happen to unfold more gradually, we'll look at that list a little bit later. Does it happen at a specific time of day or all day? The reason you ask this question is this: something that specifically happens only at one time of the day is much more likely to be environmentally driven by something or someone or a system that's occurring. For instance, in the morning, resistance to care, or in the evening, sundowning, versus a behavioral problem that occurs kind of all through the day. Something that occurs all through the day is much more likely to be biologically linked. And things that happen at specific times of day, you can kind of zone in on some sort of environmental issue that's specific to that time of day. It is very important to identify triggers if you can find the triggers and eliminate them. And also remember to keep in context to the patient's family and social history, because some behaviors that someone who's caring for them, who's unfamiliar with them, might consider a problem, might be part of their life. So for instance, I knew a guy who was a boxer who on his very first day of being admitted to a facility got into the elevator with his family, thank God, and some people from the facility. And when the elevator bell rang, he kind of put his fist up like he was going to box. And he was being kind of jovial with that, but it freaked the staff out, and the staff assured them, nope, he's kidding, and he was a boxer, and that's why I did that. So behaviors with an abrupt onset. So this first basket, first think medical disorders across the board. And I think that for the most part, people are pretty familiar with this. I'm going to hit on some of these factors later a little bit more, especially delirium. The other thing that creates sudden changes are sudden changes from the environment. The caregiver all of a sudden had to go into the hospital, and now there's a new caregiver. Someone's in a new location. They took grandpa on vacation, and it's just really overwhelming. And that location is largely contributory. Or there can be something secondary in the environment. I had a patient come in who was upset, and it was nothing wrong with him or the caregiver, but they had just moved their grandson in unexpectedly, who had some issues with alcohol consumption, and that was really upsetting the alcohol cart. And as soon as we moved him out, grandpa's behaviors went away. So things that start a little more slowly, top of the list, psychiatric disorders. So for instance, think about the development of depression happening across, 6, 8 weeks, 2 months. Along with depression, you'll see when an individual has dementia and depression simultaneously, you will see irritability as a key sign, not so much that affective sadness, but irritability and delusions, very high proportion of delusions. So the psychiatric disorders top the list. Could it actually be progression of the dementia into the next stage of the disease? We miss this one as professionals all the time. So that's signaling that someone's moving from early stage to middle stage, or middle stage to a late middle stage. And could it be the caregiver? I don't like to push or talk that much about caregivers negatively because they put up with so much, but sometimes their behavior can contribute to the irritability and behavioral challenges of their care recipients, because they don't understand the diagnosis, because they don't want to acknowledge the diagnosis, and a whole host of problems that I'll get into in a little bit. In addition to this, ineffective plan of care may be the issue, and I'm going to give you some very solid examples of that later on in this lecture. Personal history, we just talked about an example with that. And the environment, a very big deal for someone who has a dementing disorder, because their frontal lobe cannot handle that simultaneous intake of stimuli. It creates a lot of confusion and irritation. So decode all the potential sources of the behavioral issue. So the first question to ask yourself or to understand is that every person has a different profile of what contributes to their problems. This slide I put together myself based on research, and that is there are a number of factors that are very predictable that contribute to behavioral issues. And that, looking here, your degree of cognitive impairment, degree of resistance, which is a very big problem for caregivers to try to give care, render care to a resistant individual. So communication issues, caregiver approach, so on and so forth. So each person has their own profile of what contributes to their agitation. And there's a large heterogeneity of what could be contributing to this factor. And sometimes I think this very issue, the fact that this is much more complicated than people think, some of the group interventions for non-pharm approaches have a lot of difficulty in measurement and also reaching significance. And I wonder if this heterogeneity isn't part of the issue, because one solution for one person is not the solution for the next. So the general idea is for you to teach your families and your staff to not think of behavioral issues as a singular linear relationship. There's not one thing that causes behavioral issues. It's really much more like a multiple regression where you have multiple factors contributing to the outcome. And so this kind of linear, simple thinking is how we learn, and it's where we start, but it's not very effective in terms of solving behavioral problems, because the behavioral problems look much more like this, the multiple regression with multiple factors contributing to the outcome, and some of those factors being much more important than others. So if we look at something just like agitation, the very same behavior can be caused by different factors and reasons. So if someone just tells you someone is agitated, don't assume you know why they're agitated. It might be a reflection of, for instance, damage in the frontal lobe, impulsivity, I want to go now, and then they become agitated, misinterpretation of communication. The statement, she talks down to me, individuals with dementia have a ripe opportunity for misinterpreting signals and words that we use to them, and that often causes issues. Sometimes it could be the environment being too noisy and overwhelming. Sometimes people can just get unhappy and misinterpret a social situation. Statements like "this is stupid," or even at the bottom, indications that there are some language difficulties that frustrate folks. These are all ways somebody might get agitated. So agitated behavior, who knows how many sources that might have, but don't think of it as a singular source. In addition, these are behavioral problems are all related to each other. So here's another way to look at this agitation. So for instance, an individual is depressed, they have a lot of irritability with it. You're asking them to do something they don't really want to do, they become agitated. Or for instance, the last example, something happens to embarrass them. They may be a more disinhibited person and they become agitated. So there's relationships between other behavioral challenges and, for instance, in this example, agitation. So nothing is simple, nothing is linear, and nothing just has two variables, causation and effect. So looking at this grocery list here, these are the things that we look at to decode why a behavioral issue may be happening. So is this related to the dementing illness directly? Is that what we're seeing as part of the things that the patients and families are complaining about? So if you look at this slide, you'll see a little breakdown of behavioral issues, and you might share things like this with your families, because they often think that a diagnosis of dementia is strictly a memory problem, and then they're very surprised to learn later that there's so much more that comes with it. So for instance, problems with memory, learning language, abstract thinking, all of these can generate behavioral issues down the line. Definitely the dysregulation of emotions and labile moods is an issue. And it also could be one of the, what we call 4 big A's of dementia. And these are manifestations secondary to the changes in the brain. The 4 A's: amnesia, aphasia, agnosia, and apraxia. So the big problem here in the brain, and if you could kind of explain this to your families, is the loss of integrative functioning in the brain is really where the big problem comes in. The specific loss of gray tissue in certain areas, for instance, a language area, these are bad things. But the bigger problem is the communication between all the lobes and the firing of the white matter appropriately that really causes issues. So I'm going to go over the 4 A's kind of quickly. These 4 slides I would encourage you to copy and hand out to your clients as you need. They are designed for families with behavior listed on one side of the slide and responses, potential responses, on the right. And it points out some things that they may not really be understanding are part of the disorder and part of the memory loss, not necessarily a behavioral issue per se. Asking questions over and over. And sometimes people minimize that and think that that's not a big deal. And I will assure you, if you haven't worked with enough people who have dementia and spent hours and hours with them, this asking questions over and over can really test anyone's patience. Losing belongings and accusing others, it's super common that we see. So on the right-hand side, we talk about the importance of being patient and creating a structure or routine of activities. I'm going to hit on this later because this is very important. Routine and structure are the friend of someone who has a dementing illness in order to produce predictability and control and calm. So routine is a very big deal. Giving directions one step at a time is very important. If you think of a mini mental, at the very end, we give that 3-stage command on purpose. Take this paper in your left hand, because most people are right-handed, fold it in half and put it on the floor. We say 3 things, stack them like that. Somebody with a memory disorder is not going to remember all 3. And that's a test. But in daily life, it's very common for us to say, Mr. Jones, can you come over here, sit down, and take off your shoes? Well, I just gave him a 3-stage command. So when I train nursing assistants, which I do a lot, we go over this, and I also tell them why we want to break it down into single stages. And if you do that and people understand why you're asking them to do things in a certain way, and you give them a biological science reason, they're much more likely to follow through with that and even share that with other individuals. So it's just a little pearl of wisdom there. Okay, going to the next aphasia, this inability to express yourself. Early on, it's an expressive aphasia. Later on, it's a receptive aphasia. And right around the middle stage, you'll start to see the receptive aphasia kicking in. So now I'm not 100% interpreting what's being said to me. Sometimes the word makes sense to the individual, but the context does not. But communication is an area that is ripe for errors in perception and interpretation, and can cause some troubles. So early on, an individual might have trouble expressing themselves and then show some agitation or frustration. But later, if they're not interpreting what we say correctly, that is an issue. And so the change between an inability to understand abstract concepts starts to erode in those middle stages, and concrete language is more meaningful and a little bit safer for us to use. So sometimes abstracts are hard to interpret, and sometimes just regular communication. I remember saying to one of my patients I needed to take her vitals. Now, I wasn't looking at her when I said this, and she got really angry and said, "You're not taking anything of mine." And I thought, well, I did just say I was going to take something from her. So I apologized. I said, well, I would never take your things, but I would like to check your blood pressure. And she was fine with that. But then on my way out the door, she reminded me, don't you take any of my stuff. So point well taken. So to the right-hand side, eliminating distractions, obviously, for communication, because once again, that frontal lobe cannot keep one priority in front and listen to all simultaneous other stimuli and keep them in the background. So this is a weakness of the frontal lobe. This is why eliminating distractions becomes highly important. If you really need someone's attention, turn the radio down, turn the TV off, and get that eye contact first, lock eyes, and then communicate that message. Waiting for an answer is also very important, because processing is the #1 problem with aging. It takes people longer to process things, and when you have a neurodegenerative disorder on top of that, that processing speed can be significantly slowed down. And the last thing I'd like to say about this slide is being aware of nonverbal behavior. I always include in many of my lectures a whole section on body language and nonverbal behavior, because often if we know someone's signals, we know them well, we can tell when we're going down a path of agitation. And when you're thinking about aggression, and I teach classes on aggression, it's usually a cycle that kind of escalates across time. And if you can identify those behaviors that are associated with increasing agitation of your client or your family member and back up, you can often avoid aggression and either verbal aggression or physical aggression. You can usually stop that cycle if you recognize it early enough. So agnosia, now this is a perfect example of this lack of integrative function in the brain, where agnosia, you can see an object, but you're no longer utilizing that object properly or recognizing the object for what it is. Now, a family will tell you, I'm wondering about my mom's vision because she's doing some weird stuff. And if you look at the photo that's in the upper right-hand corner of this slide, you'll see a glass of water with a pencil in it. So if an individual has significant agnosia, They can look at the object and their visual acuity is absolutely fine, but what that object is not connecting in the other parts of the brain, and that's the loss of integrative functioning. So if you have a straw right next to a pencil, they're shaped exactly the same way. So it wouldn't be unusual for someone who has agnosia to take the pencil, put it in the drink, and say, well, this is a lousy straw, it doesn't work. It is perfectly understandable. And I would say the most important thing to remember about agnosia is it creates safety issues. People will handle objects in an unsafe way, like say, for instance, lift the knife more by the blade than the handle, because you're not really processing that one end is sharp and the other end is the handle. I've had people pick up non-food items and try to eat them. A rock, I was walking outside with a lady who put a rock in her mouth, and I thought, oh my God, it's just the right size to occlude her airway. So after she had it in her mouth for a second, I said, can I see your rock? Because I forgot what color it is. And she spit it out, and I got the rock out of her hand, and I thought, oh my God. But agnosia can cause safety issues. Walking into obstacles, wanting to go home when they are home. So on the right-hand side, it's our job to make the environment safe. If they don't know who you are, you keep introducing yourself at every introduction. It's just not a problem to do that. Keeping clutter to a minimum and looking around in the environment, much as you did if you're a parent when you had younger kids. What in this environment could be misinterpreted or creates a safety issue, and get it out of the way. Last thing I want to say about this is also with agnosia, sometimes individuals will look at themselves in mirrors and not recognize who's in the mirror. I got a consult to go see a patient because they thought she was hallucinating. So I came into the room, talked to the lady, and I said, what is it that's going on? She says, there's a lady over there, and I see her all the time. And the staff thought this was some sort of visual hallucination. So I said, well, where exactly is she? So she walks over the mirror and points, and she goes, there, right there. She's there every time I come over here. So what was happening was she was seeing herself in the mirror, not getting it, it was the mirror. And it was very upsetting to her that someone was in her room. So we covered the mirror and the problem was solved. So just keep that in mind. Apraxia, also very high-level behavior that we really don't think of in a daily basis, just getting in and out of a car. For instance, you would need to crouch, stoop, spin, approximate distance. So there's all these things that need to happen simultaneously, and when your brain is healthy, it fires nicely and you can do it. But for a person who's caring for someone with dementia, it doesn't work this way. And if you've ever been in a parking lot and seeing an elderly person trying to get another elderly person in the car, sometimes you'll be able to see this yourself. For instance, like getting in the car and putting your whole head in first, that's not going to work. Putting your foot in first without the rest of your body doesn't work. So apraxia is a big deal. We find this more with people going up and down stairs, walking till they hit a threshold and then just freezing, because initiation of a task with apraxia is one of the hardest parts. Putting clothes on backwards, putting clothes on, putting your underwear on over your pants. We call that the Superman kind of a syndrome, because Superman wore his trunks on the outside. But feeding is a time that we would see this, in grooming. So you want to simplify the tasks if you can, and pay very close attention. Tell your families to pay attention to when the task breaks down and intervene, then get them back on the task, and maybe they'll be able to finish. The more we allow people to do for themselves, the better they are going to be, and the more those neural pathways are going to fire and hopefully work a little bit better across time. Because jumping in and trying to finish a task could create sometimes the client's resistant to that, and sometimes the caregivers just get so upset because they have to jump in and do yet another thing. So That's the story with apraxia. Feeding is definitely a time you would do that. And what I have here, the last comment, hand over hand chewing. If you can put a spoon in someone's hand and get the first couple of bites in, they will be able to continue this task. Sometimes with apraxia, they'll get lost about halfway through the feeding with a spoon in their hand and not quite be able to figure out how to get the food from the plate into their mouth. You take their hand again and start them over, and you'll be surprised how many people can finish feeding themselves, which for a staff is very important, and also for the family members as well. So, decoding behavioral challenges. Are these behavioral issues related to medical problems? Well, we've talked about some of these already. I just want to hit on delirium specifically, because delirium, as you know, as a group of medical people, that it takes two forms. You either get hypomanic, where you're very active, and it's very easy to spot delirium in a client that's a little bit hypoactive. It's not as easy to spot delirium in a person, who's, I said that backwards. Hyperactive is easy to spot. Hypoactive often gets ignored because they're not creating any kind of behavioral issues. They're difficult to rouse, and sometimes staff don't understand that that's actually bad and needs to be reported to whoever the healthcare practitioner is. So watch out for the delirium, and specifically lower levels of consciousness and hypoactivity. Meds always a consideration high up on that ladder, and new medical problems. And the last thing I'll say about behavioral issues related to medical problems is pain, because people with dementia often don't manifest pain as other individuals might. Some people do not hold their back and say, ow. Their pain is manifested in increased irritability, all of a sudden, a sudden onset of sleep problems, or a lack of communication. So pain is a significant problem with people. There's a guy from Hopkins whose name's Peter Ravens, and he wrote The 36-Hour Day. And one of the studies Peter did right before he retired from Hopkins was a study looking at giving PRN Tylenol more generously and behavioral issues. And lo and behold, Tylenol solved a lot of problems and minimized some of the behavioral issues in people who were in assisted living. So just be aware, pain is not expressed in the same way. And I will say the last most important thing about this is do not ask someone about their pain when they're sitting perfectly still. Because if I come up to someone who has, for instance, back pain upon movement, they're sitting perfectly still, and I say, oh, are you having pain? Of course, they're going to answer in the moment. And at that moment, the answer is no. And they'll say, no, I don't have any pain. So you kind of wonder what the staff is talking about. You need to get people up, move them, then ask them about their pain. Because as a historian, they will speak to the actual moment you ask them if they have pain, rather than reflecting back on the morning when they had to get out of bed and they had a lot of back pain upon rising. Okay. Are the behavioral issues related to psychiatric complications? So we call these the secondary symptoms of dementing illnesses frequently, because there are quite a few people will have issues related to depression at some point during their dementing illness. That's probably the most common. So just keep in mind that when depression occurs simultaneously with dementia, as I said earlier, irritability is a very common problem. Not so much these affective symptoms you would expect to see, the tearfulness, suicidality, so on and so forth. You really don't see those as much as you will irritability and delusions. For some reason, we did 2 different research studies on depressive symptoms and treatment of depression in dementia in the psychiatry department of Hopkins, and just found that delusions were very, very common. Anxiety, I would say, is the very next most common symptom that we see, and it's kind of that generalized anxiety. Rarely it's linked with a specific trigger, but kind of a generalized anxiety provoked when, especially in an unfamiliar situation. Pretty common, but anxiety can be very limiting and frustrating for the family members to work with. Apathy is an interesting issue because there's that loss of the motor drive in the brain, which is a biological event in dementia. And it can look like resistance to care to a caregiver. So it's very important for any individual who really has apathy that the family understands this isn't resistant to care, but this is a biological drive that has been impaired. People with apathy are not cranky. It is not depression. It's a first cousin to depression. But individuals with apathy would be, for instance, very happy to sit on the couch all day long and watch The Price is Right, where their family's like, oh my God, she must be depressed. She's on the couch watching The Price is Right all day. And the client is perfectly okay. Not that that's good for them, but it just shouldn't be confused with depression. And psychosis generally is easier to identify when someone has frank delusions, which are much more common than hallucinations. And one last word is this: any preceding mental health issue that was present prior to the dementia will continue after the dementia. And just like a weatherman, I will tell you, it will persist, diminish, or worsen, or it'll rain or not, depending on the weather. So this is an unpredictable situation. How the preceding mental issues will then dovetail with a concurrent neurodegenerative type of problem within the brain. And sometimes when you're solving behavioral issues in someone who has this mental illness history and a current dementia, you really sometimes will not know which one you're treating. Is it the previous anxiety disorder or is this dementia? And people will ask, and honestly, sometimes there's just no way to know. You're going to treat them the same anyway. So are the behavioral issues related to the environment? Once again, I was citing that frontal lobe and that inability to tolerate multiple stimuli simultaneously. It can really lead to irritability and feeling very overwhelmed. So noise, distractions, loud TVs, an environment that's chaotic, too hot, too cold, or even clutter in a room, I've seen people react to. Bringing your relatives to the airport, when you walk into the airport, there's kind of an ambiance of stress that most of us will feel. And sometimes our clients will really feel this and become very anxious very quickly. So just be aware that that environment can play a big role in how a client would function. Sometimes it is the caregivers. And like I said, I don't like to pick on caregivers. I've been one myself more than once, and I know how hard that job is. But sometimes caregivers, we don't have halos, and caregivers can become short-tempered with their care recipients. Sometimes they can demand excess function that the client doesn't have. Like, you could do this if you try, try, and they really can't do that. So then they create some behavioral issues that weren't there by their own behavior, arguing, sassing of clients, smart aleck remarks under your breath. None of us would like that. And when a caregiver does that to a care recipient, of course, you're going to get, you get what you give, is often what I say. So are these problems related to the structure of the day with lack of routine or poor scheduling? So I'm going to show you a very nice piece of work that was done by two nurses at the University of Iowa and Holland Buckwalter. And the PLST I have written on another slide. It's progressively lowered stress threshold. This is what we're talking about here. So the dotted line that you see across the top of the slide, normal stress threshold. This is an individual with an intact, healthy brain. It takes a little bit more for us to hit our limit than an individual with a dementic illness. So the lowered dotted line represents an individual with a, say, middle stage type of dementic illness. So left and right, AM and PM. So you have activities that happen in the morning that take you up your stress, and then maybe they rest a little. And then there's another stressful event. Maybe I need to shower and wash someone's hair. And then in the afternoon, I need to take them to a doctor's appointment and then to the post office. And then I try to pick up the kids from daycare. That's a day where come 7 o'clock in the 7 p.m. in the evening, an individual might have sundowning. And this is a slide that depicts sundowning. You have your AM, you got through okay. But because of the way that day was structured, by the evening, by 7 o'clock, that person is now having catastrophic reactions, come 7:30, or right before bedtime. So a better way to organize that day is recognizing that that lowered stress threshold needs to be identified and worked with. So you would say bathe someone, then give them a little time to chill out. Go to the post office, give them a little time to chill out. Get him ready for bed, give him some time to chill out. You want to know where their threshold is and try to stay underneath it by the way you design the day. And this is what I mean by poor planning, when there's a disregard for an individual's stress threshold. Now, I will say sometimes a caregiver cannot do what's on this slide. They cannot rest them in between because they have 3 or 4 things that have to be done that day. And they have to take your care recipient to the doctor's office, to the grocery store, to the post office, so on and so forth, because they can't leave them alone. Not a terrible thing as long as that caregiver understands in the evening that person may be very worn out and have some behavioral issues that they wouldn't have if they had a more balanced day. So here's what we're looking for. Some rest periods, AM and PM, not sleeping, but just chill, low stress, low chaos situations. Observing for the signs of stress. Remember, I was talking about those behavioral indicators that someone's getting agitated or more stressed. Reducing stimuli. When you start to see this, back off or stop the task that you're doing, and know when to reapproach. So that alone, this whole approach right here, this progressively lowered stress threshold, I think is quite a big deal, and important that your caregivers and families understand how they can use this to their advantage. So now you devise a plan. So here's the plan stage. You're going to either change the caregiver approach, the environment, change the schedule or the routine, or employ some specific intervention. Do the plan, and I'm going to give you an example of this in a minute or two. Implement it, know exactly what you're going for, with a time frame and a promise to look back, and get everyone on the team to understand this. Especially in a facility, you need the entire team to approach something in a very similar manner, or you will unwind some of the progress you're making. So, and determine if it works. Was it successful? Was it partially successful, which is most likely going to be the answer? What worked, what didn't, and where do we need to go from here? Because behavioral problems are generally not solved by the very first pass or the very first time. So putting it all together, and here's an example, and this was a real event that happened. We had a client at one of the facilities that I was the scholar in residence. And this individual was very sweet, but all of a sudden he started having behavioral challenges going on. He became uncooperative while he was dressing and undressing. and during bath time. And the caregivers were saying, he's pulling away from us and saying, you try to kill me, so on and so forth. But what's underlined at the bottom of the slide and what struck me immediately by taking an inventory, as I told you in the very beginning, is he was usually cooperative and pleasant the rest of the day. So immediately you need to zone in on that morning time, because remember I told you biological problems tend to happen all through the day versus problems that are more environmentally, like the origin is more environmental. So here's what we did. We looked at this guy and took as many factors as we could to try to figure out how many things are potentially contributing to his behavior. So this individual had trouble with apraxia, and so some of his clothing was probably getting frustrating for him to work with. He also was aphasic. He was having receptive aphasia at this point because he was a middle stage patient. From a medical standpoint, we found out that he had an old torn rotator cuff that was never really dealt with. And every so often when that thing acted up, it was painful. And guess what? That was one of the biggest problems that was happening with this man. Psychiatrically, nothing really was going on. From an environmental perspective, we did recognize that he was very easily overstimulated and had a startle reflex. So he was a little bit jumpy. The caregiver, in my opinion, was over the top in trying to demand that he do certain things that he just couldn't do. So he was reacting poorly. And we were trying to do everything for this guy early in the morning. So here's what we did. We put this together. The goal was to decrease his resistance and his issues with dressing and undressing. When we rolled him out of bed, we let him stay in his pajamas and have breakfast. And I know that that's not the policy in a lot of places. You have to have your clothes changed before you go to the day room to have your meal. Well, the world did continue to rotate on its axis, even though he was in the day room in his jammies. The other little secret is, and this is a very good idea for people who don't like to change clothes, we learned to have him sleep in the clothes he was going to wear the next day. So at the very end of the day, we put him in sweatshirts and sweatpants. Let him sleep in that. He wakes up the next day, boom, he's ready for the day. We gave him Tylenol with his breakfast. We changed the kind of clothing he had because he was apraxic and we wanted to minimize the raising of his arms. So we got rid of over-the-head sweaters and used button-up shirts and a number of the things that are on this slide here. We started bathing him in the afternoon when his muscles were more warmed up, and pain tolerance is really the strongest between 10 a.m. and 2 p.m. So, closer to 12:30 or so, we were giving him his bath. Excuse me. Having everything ready in that bath because he was easily startled and jumpy was very important. And we changed caregivers. We gave that poor caregiver that was so frustrated a little bit of a break and a little bit of coaching, and used someone who was a little more calm, lower voice, a little more chill, and very a little bit better able to distract the individual when he started getting bent out of shape. We solved this problem in less than a week, went away. So just to keep in mind, the plan has to be consistent when it's done, especially with different shifts, different people. And tell your clients and your families and your staff to expect to have to redesign the plan. It's very rare that you get a home run and everything is fixed, boom, all of a sudden. Part of your solution will work and part of your solution might not. So when you go at it for round two, you take advantage of that and understand that reductions in intensity or frequency of a problem, any reduction in either one of those is indicating to me that you're on the path of success. And then finally, we can't get rid of everything. There's some things that we have to learn to tolerate. But if we can reduce frequency or intensity, the ability to tolerate is a little easier. So last couple slides here. Caregivers really also benefit from routines because their responsibilities will often mushroom into what we call the secondary areas of life. their ability to take care of themselves, and any interest that they might have outside the household. So routines are extremely helpful for caregivers too. Care recipients benefit from routines because it helps provide structure for sleep-wake cycle. And if you've ever worked with a client who's really gotten that reversed, their sleep-wake cycle, you know how hard that is. And it decreases anxiety for both the caregiver and care recipient because they have a sense of predictability within a day. This is the window that we do this. This is the window that we do this. And they know if they can't get certain things done by certain times, then maybe that needs to not be done that day. The other reason caregivers are really helped by routines is because it takes the things that they can control and they exert control over them. So we know we need to get someone clean. We know we have to give someone fed, so and so forth. So making those very as structured as you can and routine puts that organization to it and minimizes the amount of time it takes to do it. So they have some control over those factors. The more control a caregiver has over stuff like that, the more energy they will have to deal with the unexpected events that absolutely are going to happen. So your ability to cope with the unexpected, it just works much better when you know what you have to do and you know what to give up in order to cope with this new and unexpected event. So you're really getting into what I call in the middle of this slide, what needs to be done versus what's nice to be done, because the flexibility has to be there. We can't do things the same way all the time. There is no right way to do things specifically, especially if someone's placing someone into a facility. A family really has to let go of the way they did things and accept imperfection as part of this situation. If things are done less than perfectly, but they're done safely, we have to be pleased with that. And family members are sometimes surprised to find that other people find easier ways to accomplish tasks than what they were doing at home. So the right way is people who are married to that inflexibility is not going to be working for them over time. And always separating what needs to be done versus what is nice to be done are two different things. And so when the emergency comes, the niceties usually go out the door, the needs stay. So even within a day, though, I would like to just emphasize before I stop that we have to create some pleasantries here. We have to put something pleasant back into a day. If we only interact with folks when they need to be touched or when they need something and they never experience praise or pleasant events, behavioral issues will eventually occur. So providing praise and acknowledgement, some sort of positive social interaction on a daily basis, and meaningful leisure activities go a very long way in making someone's behavior kind of stay on an even keel. So positivity has to be part of it. And you can't just warehouse people and work with them when they need something. They also need some positivity as well. One of the last things I'll say is you as the healthcare provider cannot be the only source of information, service, and support. You set expectations early in the process that, yes, you need to be able to access information for yourself because I cannot be the only source. Give people good websites to work with, the Alzheimer's Association, Alzheimer's Disease and Education and Resource. There's a number of good websites, and tell people what they are. Send them to websites that you know are good. And when they come back in, ask what they've looked up. And if they say none, keep asking them at every visit until they start to take some initiation themselves for finding information, because you cannot be the only source of knowledge and support. This is the Alzheimer's Association, the phone number, that's the 24-hour helpline. They have multiple language assistance, Korean, Spanish, Arabic, so on and so forth. trained staff that can answer questions and solve questions for your family members that's not you. And it's free. And they have loads and loads of printed information that can be passed along to families that are very good, guided